Our next speaker is Denis Rozkov. He graduated in 2009 with a bachelor's degree in nursing. He worked 7 years in the operating room as a nurse in cardiac surgery before moving to Bristol in the UK, where he worked as a senior cardiac practitioner and became a trainee in perfusion in 2022. He is interested in goal-directed perfusion, CO2-derived perfusion parameters, and AKI and cardiopulmonary bypass.
So I would like to thank, first of all, to Sanibel Committee for bringing us all over from, and it's such a pleasure to participate in this wonderful event and see how you guys do things differently. So I am Denis Rozkov from University of Bristol in the UK, and I want to speak about AKI and CPB and look at continuous DO2 and renal NIRS as prognostic marker in CPB AKI. So why do we care about AKI? Well, first of all, it's prevalent complication of cardiopulmonary bypass. And the pooled incidence rate from all studies from systematic review and meta-analysis from 2016 were determined to be 22.3%. Interestingly, a study that was done here in USA by Al-Sheikh in was published in 2017. They looked at AKI impact for patients undergoing cardiopulmonary bypass, and they found 9.8% incidence, although they only looked at cabbages and valves. But I hope that this can be attributed to increased awareness of CPB AKI and implementation of better practices. So CPB AKI can be stage 1, 2, or 3 according to KDIGO criteria, and most of the AKI occurring in CPB, like 90%, are mild. But even mild AKI increases your mortality chances. So any stage AKI increases your early mortality risk by 2-fold, while AKI requiring renal replacement therapy, AKI chances by mortality chances by a 5-fold. Another aspect is financial impact, and that's the very same study by Al-Sheikh looked at the difference. So the mean hospitalization cost of the patients with AKI was $77,000 and almost $34,000 for cases without AKI. Now, observational study of 1,846 patients by Yang and Ma from 2020 demonstrated that even stage 1 AKI results in reduced survival 15 months down the line from the surgery. And ITU, hospital stay, respiratory dysfunction, cardiac events, and 30-day mortality are increased in AKI patients, hence the increased price of hospitalization. Now, how do we diagnose the AKI? Well, at the moment, AKI criteria are the rise in serum creatinine level and decrease in urine output. So the limitations of criteria are well known. Serum creatinine lags behind GFR reduction, and it takes more than 24 hours to increase significantly after the injury, and it is affected by patients' muscle mass, liver function, and gastrointestinal excretion. Urine output is also not too sensitive, with a third of AKI patients being non-oliguric. So current markers rather show renal function deterioration than the actual damage. So what are other biomarkers that can be used to diagnose kidney injury? Numerous studies identified potential biomarkers of the tubular stress or damage that can be used to quantify the actual damage, like cell cycle arrest biomarkers, tissue inhibitor metalloproteinase 2 / insulin like growth factor binding protein 7, neutrophil gelatinase-associated lipocalin, kidney injury molecule 1, and cystatin C. So the Sapphire study was done in USA in 2013, and they compared the cell cycle arrest biomarkers to the rest of the potential biomarkers, and they found that TIMP and IGF-BP had best predictive value with receiver's operation curve of 0.8, while the second closest was 0.72 by neutrophil by NGAL. So the new biomarkers can quantify kidney damage rather than just deteriorating function, as in case of serum creatinine and urine output, but ultimately their usefulness is limited because their prediction is compared by AKI diagnosed by serum creatinine and urine output. So what are preoperative risks then? So advanced stage, due to decreased number of nephrons, kidney mass, and renal reserve, from decreased renal reserve from aging, preoperative chronic kidney disease, which makes sense as kidneys will hardly do any better if the function was impaired before. Anemia, which will be further aggravated by the cardiopulmonary bypass prime, causing hypoxic injury. Hypertension due to glomerular injury and decreased vascular compliance. And emergency operations, because patients were already unstable before undergoing surgery. And preoperative radio contrast, which has a direct nephrotoxic effect. So intraoperative risks are mean arterial pressure changes. So anesthetic induction induces hypotension. Then we go on bypass. The MAP decreases again. Most of the perfusion guidelines also tell us to keep the pressure within the range of 50 to 80 millimeters of mercury, while reported kidney autoregulation threshold is 80 to 180. And then change of pressure pattern from pulsatile to non-pulsatile. CPB induces shedding of the endothelial glycocalyx layer lining all the vasculature, exposing endothelial cells to interactions with platelets and neutrophils, activated platelets and neutrophils, and inflammatory process. So systemic inflammatory response is triggered by coagulation cascade and complement activation, and which both activate neutrophils and platelets and upregulate inflammatory cytokines. While usually clinically insignificant, extreme form of systemic inflammatory response may lead to multi-organ failure, including kidneys. Most observational studies link type of operation to AKI incidence with complex cases like double valves, complex aortic cases, or valves in cabbage having higher AKI rates, possibly due to longer bypass run and deeper cooling during cardiopulmonary bypass. The CPB time also affects AKI rates, and systemic review and meta-analysis from 2016 stated that CPB time increases the chances of AKI more than any other intraoperative or preoperative factor. And probably most important for us is the hemodilution or low delivery of oxygen. So it all started in 2005 when Ranucci published this paper where he came up with the concept of goal-directed perfusion and identified a number of 272 mils per meter squared, below which your AKI chances in risk increases significantly. Then, of course, observational study is not the hardest piece of evidence in the science. So Ranucci set international randomized controlled trial called GIFT, where he compared the conventional CPB that was aiming at cardiac index to goal-directed perfusion, which aimed at DO2. And the study was published in 2018 and showed demonstrated superiority of goal-directed perfusion, and the number was updated to 300. And then in 2019, Mokaida did time of DO2 under the curve and he came up with a number of 300. What was interesting in the study that he demonstrated that for the cases that even with a long bypass run, if they don't go more than 15 minutes under that threshold of 300, the AKI rates are comparable with those with short bypass runs, but if they go more than 15 minutes under the threshold, suggesting that DO2 could be more important than just time spent on CPB. So how can that 280 and 300 by Mokaida can be explained? So we use also, his study was set with the Stockett S5 pumps and Connect system, and the Connect system calculates your DO2 according to your Stockett pump flow. And we also use in our center Stockett pumps with quantum monitoring. And so for this case, that was pediatric case, we used, the flow was 1 liter on the display there, but on the actual measured flow behind all the shunts, it was 850, which gives us 15% difference. So in case of, so that would drop down that number found by Mokaida to 255. So why kidneys are so susceptible to hypoxia? If we look at medullary blood flow, in physiological conditions, the PO2 is 10 to 20 millimeters of mercury, which is because of oxygen shunting from descending vas erecta to ascending vas erecta, which is already hypoxic. And with hemodilution and MAP reductions on CPB, that goes even lower and causes hypoxic injury to the tubules. So hypoxia is a common cause of injury, and oxygenation monitoring can provide a window to take an action to avoid further injury and reduce AKI. So a study by Lanamir in 2017 on renal blood flow in CPB had patients cannulated renal vein and observed how renal blood flow alters with CPB commencement. As we can see here, renal blood flow remained pretty much the same, but delivery of oxygen reduced significantly, mainly due to hemodilution. Renal vascular resistance increased and redirected blood away from the kidneys, even though systemic perfusion increased, as we can see here from the ratio of renal blood flow to cardiac index. Now, sticking renal catheter in every patient is not really feasible, so another study in 2020, also with renal vein catheters in cardiopulmonary bypass patients, explored if NIRS placed over kidney correlated with renal vein oxygenation, and found a good correlation with error rate less than 20%, which is good and as for between methods. Another study by Wakamatsu in 2023 in pediatric surgery used renal NIRS to see whether decrease in renal NIRS can predict postoperative AKI. And as you can see here, intraoperative renal sats decrease, CPB mean renal saturations, and CPB nadir renal saturations did correlate with postoperative AKI. Also, a study by Adams in 2019 demonstrated that renal NIRS decline of more than 30% on baseline, from the baseline on cardiopulmonary bypass was found to correlate significantly with postoperative level of tubular injury biomarkers in an observational pediatric study. Now, strategies reducing hypoxia. So I proposed in Bristol, so while we're continuously monitoring our DO2 with quantum spectrum and line monitoring, also monitor renal NIRS with perfusionist being blinded. The NIRS is measured until patient is in ICU for 48 hours or is just discharged if that's earlier than 48 hours. So the biomarkers will be taken pre-op, after induction, and before leaving theater. And then we will look at AKI associations with renal NIRS, trend, DO2, and biomarkers. Once associations are established, we can hypothesize what we can do. So possible interventions are flow increase and metronidazole administration. Lanamir study in 2019 had a patient's cannulated renal vein again, and as he went on bypass, he checked renal oxygenation at 3 parameters, free cardiac indexes 2.4, 2.7, and 3. As we can see here, the renal oxygenation returned pretty much to baseline level when cardiac index was 3. While Lankadeva in 2019 did a similar study on animals comparing flow and metronidal effect on renal oxygenation, findings were similar and provided some evidence of moderate doses of metronidal also increase oxygenation, although less than the flow. But it can be helpful if situations where the flow increase is not feasible or impossible, like in off-pump surgery. So in conclusion, AKI in cardiopulmonary bypass is a complex multifactorial pathology, and current AKI biomarkers have limited usefulness while on bypass, and they show the damage that's already been done. And renal NIRS and continuous DO2 monitoring can help in preventing hypoxic injury and the kidneys, which with associations with AKI has been demonstrated by several studies. Thank you.
Okay. Well done. It's not easy to get up there. It really isn't, is it? Have you done much before?
No.
But for first time, I've got to say, you do really, really well. Yeah, thank you.
Thank you.
It's often easy for us to sit here as people who have done it for a long, long time and be judgmental. And when you think of the guys that are doing this, they're not even out on their own yet, and they're getting up in front of everybody and they're doing things like this. So to do that, regardless of where you come on the list, it doesn't matter. There isn't really a winner or a loser, because I think you four are going to get a great reception from these guys, because most of us at your stage wouldn't be able to do this. So don't forget that when you're doing it, okay? That's the first thing I would say. So I'm going to ask you a couple of questions, obviously. When you're looking at sort of AKI, do you get the impression that, say, for example, with the KDIGO ideas or the different P-rifle, that they are an adequate measure of AKI, or do you find it doesn't really match with kind of what we do, and does it fit? So
I missed the first part of the question.
When you've got the different scoring systems for AKI.
Yeah.
A lot of the data doesn't fit with kind of what we see, and there's always problems with the scoring systems. Did you look at different scoring systems and think that one would be better than the other? And
yes, so there are AKI, which is the oldest one, I think, then followed by Rifle is the oldest one, followed by AKI, and then KDIGO. And the old ones, they're like the difference between AKI and Rifle. So a lot of studies, they diagnose AKI differently. So because like all the studies used older classification, but they're still included in meta-analysis and other studies. So I know that in AKI, the amount of AKI detected is higher for the same patients than in AKI. So yeah, it does also make difference. But I think because we now most recent criteria is KDIGO, we should all just stick to it and just get on with it. That would just improve the quality of studies, of further studies.
Thank you. Any other questions? Yeah, come on.
This sort of follows on a little bit from what you've just been talking about. I thought it was excellent. Well, thanks for that. You cited our Sheik paper on one of your early slides. You gave it a review, I think, which had a 22% AKI rate, and then you cited our Sheik paper at 9.8%.
Yes.
Did you think why that might have been different?
So the study, the systematic review and meta-analysis from 2016, most of the studies that were included, they were quite old. So from I think the most recent one was 2008 in that study. So the Ranucci's paper was not available yet. So I think people were not aware yet of the DO2 impact on AKI. And then in that study they looked at patients from 2008 to 2011. So I just hope that people became more aware of that.
Yeah, I think the real reason it was lower was the data used in that paper was a administrative database. So it just used ICD coding. as opposed to a actual classification system. So it's just something to
Okay.
think about
Okay.
when you look at different sources
Yeah,
of
plus
data.
they looked only at cabbages and valves replacements, so they didn't look into more complex cases, which they also have much higher AKI.
Well done again. I think that's fine. Let you get off the stage because I know you must want to do that. But so well done again. You know, it's really good. So thank you very much.
Thank you.